Yeah, let's look at another country, Switzerland. Switzerland remains one of my favorite health insurance systems. Not because it's expensive, yeah, as people say, but because they made health insurance mandatory as far back as 1996 under a law called the LAMA, or l'assurance maladie. So, under this law, every resident must hold basic health insurance and within 3 months of arrival or birth. So, as a baby, 3 months, you must be on insurance. When you arrive, if you don't get your own personal insurance, the government will impose one on you. So, all insurers operate in the basic cover market. They must accept everyone and they cannot refuse you based on a pre existing condition, though they are not allowed to profit on the basic mandatory cover. But Swiss premiums are not income based. They are uniform across all the age bands, all the groups, all the cantons. So, on average, adult premiums hit about 449 francs a month by 2025. That's close to 500 US dollars. So, how do low income Swiss and residents afford it? They have something called the cantonal premium subsidies, which reach about half of Swiss residents. So that state pays the subsidies. That single line of subsidies is actually the story of how the Swiss model works in practice. Without that subsidy, half the country would remain uninsured. So without that subsidy, half the Swiss would remain uninsured. The Swiss system is not perfect. Yeah, out of pocket costs are still very high. People complain that it's one of the more expensive ones amongst OECD members. And the Swiss voters have rejected about two referenda for cost containment. The last one, I believe, was in June 2024. But the architectural elements of this insurance, yeah, the mandatory enrollment bit, the guaranteed issue of your insurance, uniform benefits that you receive, the non-profit operation on the basic cover, the risk equalization across insurers. Those are elements that work. So if you look at it, they follow the risk equalization of Germany, but have all these other elements that make it work. Turkey is another very good country. In 2008, they had about four parallel health systems. One was for private sector, I think they call it SSK. The other one was for self-employed people called the Bakur. One was for civil servants. They called it a Mekli, Sandig, or something like that. And one of them was for the poor, and they called it Yazil Kat or something. In 2008, they had some reform that merged all these four into a single social security institution called the SGK. So employed citizens contribute to the SGK through payroll. The self-employed pay 6% of declared income, and the government covers premium for the low-income households. So everyone gets the same benefits package. But I think you're starting to see an era of no, a common line in subsidies. So in Switzerland, Turkey, everybody gets the same benefits package. And so, why does it really matter for Africa? If you look at the current Tanzanian landscape, the NHIF, NSSF, ICHF, and several private schemes operating in parallel, that's exactly how Turkey looked before 2008. Then, if you look at Senegal with IPM for the formal sector, the Mutuelle for the informal sector, and that's the same pattern. In Nigeria, you get the NHIA at the federal level, state agencies, then you get private HMOs operating in parallel. So that's even a more complex version of the same problem. So the Turkish lesson is really that if you have so many pools, consolidating them can be politically demanding, but it is extremely useful because it leads to a more efficient system that covers more people. It leads to a clean operation. See, administrative savings from one pool instead of four are really substantial. Let's look at one case where administrative costs are too high. That really should serve as a warning case. That is the United States system. US operates one of the most fragmented health insurance systems in the developed world. Medicare, they have Medicare for people over 65, Medicaid in five different state versions, employer based plans for the working age majority, ACA marketplace plans with income based subsidies, Veterans Health Administration. You saw some time when some couldn't get insurance last year, Indian Health Service, and then they have a residual population in the US that is uninsured, and so they fluctuate. When one political party comes in, they have insurance. The next year, another one comes in, they don't. So, what's the consequence of this fragmentation in the US? So, number one, the US system spends roughly four times per capita on health insurance than Germany. That is four times. That money is not buying health. That is just going into administration, just buying paperwork. Secondly, there's a poll by Kaiser Family Foundation, I believe in January 2026, which found that at least 2,000 uninsured Americans were facing some kind of denial issue. They had been denied insurance at one time or the other. And one third had a prescribed medication by their doctor that had been denied by the insurer for the past 2 years. So, insurance that denies the care your doctor is prescribing is really not insurance. That's a failed system. And it's not out of question that it can be improved, but it can be improved. So, why does the American system fail? Number one, the regulatory stack is incomplete. That stack of laws that they need to make the insurance system work is still incomplete. Yes, there's guaranteed issue, but they still prohibit people based on pre-existing conditions. Number two, there's no risk equalization like Germany and Switzerland. There's no uniform benefits basket. If you're a millionaire, you're going to get more services than the other human next to you. And then there's no single fee schedule for providers, just thousands of payers and providers negotiating every day. It's like a stock exchange, in the traditional physical sense. So the US case serves as a warning. It's not a model. When low and middle income countries import private insurer led basic cover without the broader structural elements, risk equalization, mandatory acceptance, statutory benefits, they reliably reproduce that US style outcome that we are trying to run away from. So please don't do this. Do not import that into your country. Now let's look at Rwanda. This Rwandese one is the African reference case because it is cost effective and it has led to universal health coverage. So around 2002, the government of Rwanda would spend about $6 yearly on health. Donors financed more than half of the total health budget. But in 2024, the government per capita spending is now at about $58, and out of pocket spending has fallen down to roughly about 9%, and that's actually the lowest amongst all East African countries. Community based health insurance is now covering over 83.5% of the population. So let me just say that again, 83.5% of the population is covered. Government health spending in Rwanda has grown by almost 10 times in 22 years. And the share that the households pay out of pocket has fallen down that much. That is an African development story that most people should be talking about. How did Rwanda do it? Rwanda, if you look at it, it has two main instruments working together. The community based health insurance system itself, which was scaled nationally beginning 2005. So the community-based health insurance, or CBHI, uses a four-tier health classification system called Ubudehe. So the first category is for poor households. The second one is for those who are a bit richer, like that, like that, like that. So the poor households pay no premium and they do not copay. The state and partners pay for their contribution. People in category 2 and 3 pay around $2 to $3 per person per year. And then category 4, which is the wealthiest quantile, pays around $5 per person plus about 10% copay at hospitals. The second instrument they have that works is performance based financing. Facilities don't get paid for treating a headache, they get paid for outputs that are measurable. The number of deliveries, prenatal care, growth monitoring, and these are adjusted for quarterly quality scores. So there's a quality assigned to the service that each of them is providing. And it's not just left like that. There's district committees which go around checking this data. So since 2015, that system has been managed by the Rwanda Social Security Board, and it's now separated from the Ministry of Health. So that is what you call the provider purchaser split. So Rwanda is still not perfect, but CBHI has run a structural deficit since 2011, and there's a financing gap all through. Like most of us, we have financing gaps in our countries. Per capita government spending has not yet reached the WHO benchmark of 86, but it's actually great. Is it 86 or 78? I believe it's 86 for lower middle income countries, $86 per person. But the design of the Rwanda system is replicable. I think most countries can do it. Lesotho started something like that. So Germany, Switzerland, Turkey, Rwanda, they teach us why these systems can succeed. And then the United States teaches us why they perform poorly in most countries. What do the four that perform well actually share? The first choice is the issue of pooling, having a single national pool like Rwanda or Turkey. Or even if you have many pools, all you can do is bind them with what's called risk equalization, like the Germans or the Swiss have done. What does not work is when you have many pools, but there's no equalization amongst the pools. And that is what's happening in the US system. And that is where insurers compete. They select only healthy members and then they serve only the patients that are a bit healthier. And the ones who are sick get denials, and there's so many legacy schemes. So you have mainly what's called a sequencing decision ahead of you when you want to create something. Number one, we said consolidate them all into one pool, like the Turkish people did. If they're not, then impose risk equalization across all the pools, like the Germans did. Both are very politically demanding, and the regulator can prevent risk selection by exhortation. Um, The second choice is compulsion, or rather what you call mandatory health insurance. Every well performing system has mandatory health insurance. Switzerland, you said, had it from 1996, Germany from 2009, Turkey from 2008, Rwanda has it functionally through local government enforcement. And why does this matter? This matters because it stops us from doing that thing called adverse selection. So if insurance is voluntary, of course, the people who buy it are the people who expect to use the services. So they actually seek, most of them. Most of the healthy say, why should I spend tens of thousands on insurance that won't help me? I never fall sick. So it tilts towards the ones who are very sick. And so the premiums rise. Healthy enrollees tend to drop out. The pool tilts again, and voluntary community health insurance really It plateaus around 60%, the 60% mark. It's very hard to find one voluntary one that has 80% enrollees. It's really tough. In 2008, for example, Tanzania's ICH reached about 6% at its peak, but that's still low. Compulsion alone or mandatory health insurance alone is not enough. If you look at the Kenya Social Health Authority case, we launched mandatory enrollments around 2021 and again in 2024 with the new SHA. Within 12 months, we'd already inherited the NHIF number. 27 million Kenyans were registered. But if you look at that's front office, so the front of the house success, you know. But when you look at the number of people who are actually paying, it's just 5 million. So less than a quarter of those who are enrolled are actually paying. They're using this means testing. Only 3.3 million people had been means tested by 2025. Very few health facilities were receiving their monthly payments. So the operational machinery in Kenya didn't work very well. So mandatory health insurance is just one of three architectural choices. It just doesn't work alone. You need to have that operational capacity. That's what the Kenya case teaches us. Both, not one or the other. So the third architectural choice we could talk about is one that most ministries of finance want to avoid talking about. Someone has to pay for those who cannot pay for themselves. Someone has to pay it. Under the WHO constitution that your country is a signatory to, that role falls on the government. If you're starting, private sector can give you, public sector can try, development partners can do, but there are people who just can't. Even if they wanted to work, they wouldn't work. They're disabled, they're crippled. You've simply got to pay for them. Switzerland subsidizes half its residents. Egypt uses budget transfers under what they call the UHIS. Turkey absorbed the Yezilkart legacy into GSS, and so they didn't run it as a parallel scheme. Senegal links what's called the Bourse de Sécurité Familiale cash transfer to automatic mutual enrollment. So the US Medicaid is actually aimed at this kind of subsidization. But where does money for that subsidy come from? The most resilient systems for subsidies are usually those that are domestic and they are earmarked. So Egypt has tobacco, alcohol, and pollution levies. Malawi has a 2% motor vehicle insurance levy that is ring fenced for health. And sin taxes on tobacco, alcohol, sugary drinks, they generate predictable revenues. But what does not work in the long run is recurrent donor financing of indigent subsidies. We saw that in Kenya, they did about 3 years. I believe the Japanese, the World Bank, I believe UNICEF helped a bit with setting that up and other partners. But you see, given the aid freezes and that global fund prioritization, you cannot rely on external funding forever. If you build your subsidization on external funding, then you're prone to those shocks when the donors leave. Now, let's zoom in on the patient centered value chain. The three architectural choices we just discussed are really high, they're up there at 30,000 feet. They tell you how the system is shaped. But what about the operational decisions that actually determine whether your aunt, your father, your daughter, get the care they need? I have a way I like to think about this. I call it the patient centered value chain, where you track the patient from when they enter the system up to when they leave. Who did what? It's about making sure that the right cost effective partner, either government, private sector, civil society, any other, media, does their part. So this system should be designed deliberately. It shouldn't be an accident. Number one, you need to identify them. Like we said back in 2021, it's still true. We have to identify every patient that enters the system. You need to run the legal framework and the identity register. That's the government. But the last mile, the actual conversation in the village, the phone number captured correctly, filling up the form, that should be done by community health workers. There are very strong community structures in such countries: Kenya, Ethiopia, Lesotho. Ethiopia has 40,000 strong, has a 40,000 strong health insurance system, health extension worker network. Kenya has a USSD code that sometimes works, sometimes does not. The 147 hash, star 147 hash. Senegal uses a digital platform deployed around 2019. But the cheapest enrollment channel is one that already is in the village: civil society. Stage two is to really check the vulnerability and means of these people. We have to figure out what each household will pay. So, flat premiums, every resident can do that. Progressive premiums of the Rwanda Obidehe type, or the Ethiopia sliding scale, or the Kenya means test, they all need some methodology. They need field data. They need some adjudication and appeals, and the methodology needs to be validated by research. Field data needs community health workers. The appeals need a local government, like in Rwanda. If you skip any of these, you get the Kenyan failure pattern. You have 27 million who are enrolled, about 4 million means tested, and then the design now starts to become hollow. Stage three: who collects premium and who does the risk pooling? Formal workers, of course, are in the payroll, but informal workers can be reached by mobile money. Then earmarked taxes provide that system level revenue for subsidies. And then it tends to pool nationally, because smaller pools really concentrate risk, and that low income populations really cannot absorb that kind of risk. So that's why Senegal recently moved its risk pooling from commune level mutuals to those higher, larger departmental or provincial unions. Another thing you've got to check for is the benefits design and the tariff setting. That technical work. What does the system cover and at what price? This is where IQWIG, NICE, and that broader health technology assessment function actually tend to be very important. The German IQIG is one best practice. African schemes tend to pay very close to manufacturer list prices for medicines. And if we are lucky, we get some pool procurement pricing. But the analytical function of all this is really missing. So a continental health technology assessment hub around the SADC, AUD, NEPAD, ESC, that's basically the way to go. We already have regional health financing hubs which can actually play this role extremely well. The fifth one is provider accreditation and service delivery. You need to accredit your providers efficiently. The patient should encounter care. Public hospitals, private hospitals, private for profit, primary care centers, community health workers, pharmacies, laboratories, all of these participate in a mixed delivery system and accreditation. So the strength of the primary care gatekeeping function and that integration of community health workers into formal delivery, those are some design choices that actually matter a lot. Number six is claims adjudication and verification. The providers will submit bills. The strategic purchaser, be it UHIA in Egypt, RSSB in Rwanda, SHA in Kenya, will adjudicate each claim against that benefits package and that tariff schedule. So real-time adjudication is gold standard, but a lot of insurance systems don't have real-time adjudication. Some wait almost a year. We still have legacy bills from previous health insurance systems 2, 3 years back, you know. But we need to make sure that there's some independent audit that catches what that real time adjudication will miss. Another thing we need to do is look at payment performance and grievance redress. Providers get paid on time when you have a very good grievance redress system. Payment should be tied in as an output, a measure of quality. And patients should have an independent place to appeal when something goes wrong. Kenya's low payment rate in early 2025 was really a failure pattern that all countries should avoid. Grievance redress can't be performed by the same entity that is being challenged. It needs an institutional kind of separation. So these are 7 stages. Every patient needs them, every system that works needs them. And the question is whether at each stage the correct actor is leading that stage. So, who should lead each stage and who should not? Let's talk about it. Let's talk about who provides value where. So, here is my analytical move, really, my analytical thought. Each of those stages should be assigned to the actor that is best placed to perform it. Who will give more value performing that particular activity? The wrong actors for that activity should be excluded. You can't replace government in 4 functions. Of course, the government will legislate that mandatory enrollment bit. Government will hold that single national risk. Government will enforce risk equalization across the multiple tools, and government will also set the benefits package. Government should also ensure timely payment to providers. These can't be unbundled to the market without producing the same issues we've seen across different systems that seem to not to be doing well. Rwanda has made all these 4 calls. For example, when it consolidated CBHI and RSSB in 2015, Turkey did it with the SGK in 2008, Egypt did it with UHIA in 2018. But government is still not the answer to everything. Government is really weak at 3 things. Number one, last mile enrollment, especially for informal sector populations. A lot of our insurances end up being employee based schemes because most governments are unable to reach the informal sector. Collecting premiums from these populations, direct service delivery to these populations. Government is replaceable in these functions and it should also not lead the last 3. Private health insurance are a bit poor for that basic basket in low middle and income context. They don't treat the very poor very well. Yeah. Private health insurance sometimes tends to cherry pick through underwriting. They can be good at having them registered in private pharmacies and so on, but they don't do that very well for the poor population. They do very well with the rich. So, if you want to have high administrative costs, also, you give it to private health insurers. We are seeing that within Kenya, where private health insurers have come together and administering, and it's really stacking that cost. So, when you want to have this, you need to do equalization, mandatory acceptance, non operation on basic cover, statutory benefits. All these neutralize those bad incentives that you give the private sector. Without that stack, the legal stack, that regulated competition collapses. The American ACA market, for example, is a live demonstration. What happens in a country that didn't put that full stack of laws in place? Private insurance, though, are not the devil, They are really excellent for two roles. Number one is providing that supplementary cover for what the basic market might exclude. So, for example, the German PHI, the Swiss complementary cover, the Turkish TSS, the corporate medical scheme market that is large in Mauritius, South Africa, you know. Private health insurance covers that supplementary bit very well. The second is regulated competition for the basic basket, only where the regulatory infrastructure is mature. So you need to keep private insurance in supplementary covers until your basic tier regulatory stack is in place. Private insurance can also do for you that verification sometimes in tough places. Coca Cola reaches the villages, kiosks, where government is not even able to. Can they do some verification for you or some support or research? Let's go to research organizations and health technology assessment institutions. These are some of the most underutilized actors on this continent. In Africa, we need to use research institutions more for the right stuff. They can analyze claims and fraud patterns. They can validate vulnerability methodologies. They can run cost effectiveness studies that drive procurement. So we need a continental health technology assessment hub. I know there were some attempts to put in some around 2022 to 2025, but we need such, and we already have the regional economic communities that can do that. So they can save massive funds at continental scale and that no single country can do on its own. Civil society organizations and community health workers are the cheapest enrollment channel and the most credible accountability channel. Ethiopia's health extension workers have shown us, Rwanda's mutual agents have shown us that, Senegal's BSF linked auto enrollment. So, for enrollment and grievance redress, nothing really competes against the civil society. And then development partners like the World Bank, Global Fund, UNICEF, the bilaterals, others, they add value when their role is catalytic and time bounded. In terms of the information system, when they fund the information system, as they did in Lesotho, where they went house to house and found out who is actually great, who cannot pay, who's sick, who's needy. And when they actually subsidize the very poor when government had not budgeted, it accelerates the system. You start up the reserves, you capitalize its HTA institutions, build digital infrastructure. But when they fund these systems indefinitely, they produce some fragility into the system. Partners really should stay on the catalytic side of the ledger. Government should stay on the recurrent side, meaning that the government should keep assisting people, or government should keep running that insurance. So now let's look at the back office machinery. There's a layer beneath that patient facing value chain that we rarely look at critically. Most policy discussions really never look at the back office. That underwriting, actuarial pricing, insurance, reinsurance, reserve management, solvency regulation, risk equalization, health technology assessment, pooled procurement, coordination of benefits, the ombudsman. All these technical functions determine whether the political launch of an insurance system will actually lead to success. You can launch something, but when you don't look at the back office, it just won't work. These technical functions really determine whether the political launch of an insurance system survives the first 3 years. And these, in most countries, as you saw in Kenya, these are some of the last functions that receive any serious institutional investment. So Kenya launched in 2024, And now they've put in the back office, one pile after another, do this, do that, do that, which would have really worked well had it been done before. Let's look at classic underwriting. This one is really not well understood. Underwriting is actually selecting and pricing individual risks based on the health status. This is based deliberately suppressing the basic basket of every solidarity-based system that we have looked at. Germany, Switzerland, Turkey, Rwanda. This is that design choice. It's not an oversight. Because if you let insurers underwrite that basic basket, they price out the people who mostly need that coverage. So they tend to take healthy members, or they refuse the sick, as you've seen in a lot of denials in the US. Sometimes they even load premiums on the sick until coverage becomes notional. So the Affordable Care Act, for example, it had to that act of 2010, it had to prohibit that practice of selecting patients around 2010. So what really works instead is that three substitutes that we do for individual underwriting, and they need to work together. Number one, community rating. These are basically premiums that are based on the income or household category, not really on health status. Number two is guaranteed issue. Insurance should not be able to refuse you. And number three, as we said again and again, is risk equalization. Money should move between insurers ex post based on actual morbidity and taxing those funds that ended up with healthier members and paying the funds that ended up with them to the sick. Together, when you use these three substitutes and do the actuarial work without the social cost of excluding sick people from coverage, then you have an insurance system or back office that works. Classical underwriting will only survive in the supplementary tier. When some people want tertiary services like facials or surgery, looking good, better than just improving, those supplementary, then you can do some underwriting for that. But if you let it substitute for that basic basket, then it also ends up in cherry picking healthy people and it breaks the whole solidarity pool. Two implications then follow. First, when you don't have independent actuarial and health technology assessment capability, then you lose a lot of value for money. Let's look, for example, at how the German IQWIG delivers pharmaceutical price reductions of about 30 to 60% against initial manufacturer asks. African schemes pay close to list price because there's no analytical function. If we could have a continental hub that looks at this function, then we would be good to go. We would then charge just a fraction of the costs that individual countries would incur. We can do some pooled procurement in this, build the market, aggregate the market for manufacturers, invite local and international manufacturers, have a larger market for each can specialize on specific drugs, and so everybody grows. Everybody grows. Companies waste less money on their products, and countries waste less money overpaying for it. Kenya scaled SHA enrollment to 27 million in 12 months. Showed that yes, the front office worked. The back office payment infrastructure did not. Rwanda's structural deficit since 2011 is there because the actuarial pricing of progressive premiums has never been rebased since the beginning. You need to rebase that premium based on the claims. So, of course, claims increase and then you increase the premium a bit. So you need to commission that actuarial pricing, that HTA capacity, that reinsurance placement, and the solvency regulator design before you launch these insurance mechanisms. Let me close with the five recurring failures that the framework explains and the two reform options that drive most of the value. Failure one is fragmentation without risk equalization. The US precedent, you've seen it. So the fix in the US would be to consolidate and risk equalize. Both are really politically demanding, but if you don't do that, you really continue to fail consistently. Failure number two is that voluntary community based health insurance plateau at 60% coverage globally. Leave that voluntary question alone. Just do it mandatory. Mandatory does not mean you pay compulsorily. It says you have to register because then you have the data that will help you also with actuarial pricing. Senegal has seen that also, besides Kenya. The other one is registration without means testing. The Kenya SHA pattern really, the fix really should be to sequence the means testing methodology and infrastructure ahead of any political launch, not after it. Kenya is a bit late on that. Failure number four is that payment failure and provider exit. Kenya again. You need to fix this by building out claims adjudication and treasury disbursement before enrollment is scaled up. Now that you've done it, you need to also protect the strategic purchaser's institutional independence from case by case ministerial approval. Failure number five is donor dependent recurrent financing. Design partner financing exits or transition plans with reform timetables from the outset. Partners should be on the catalytic side. They should not support your system ad infinitum, not forever. Government should always be on the recurrent side. And if you're starting a reform from scratch or if you're reforming an existing scheme, there are two governance choices that drive more value than any other. Number one, establish the provider purchaser split with strategic purchasing. Rwanda did this in 2015, Egypt did it with UHIA, Germany does it through the Federal Joint Committee and the Sickness Fund architecture. So that split concentrates negotiating leverage on the demand side. It forces providers to compete on quality and unit cost rather than on political access to the line ministry. Right now, whenever you focus this on political access, that's basically it. Number two, mandatory single pool architecture and then with active risk equalization, especially if you have multiple funds like most countries. No insurer should profit by selecting only healthy members. No scheme should suffer because it ended up with a sicker portion of the population. Both choices are legislative. They cannot be implemented by a ministerial directive or by donor technical assistance. The government just needs to bite the bullet, create those laws, pass those laws. Parliamentarians push for those laws. They work best with sustained head of state political championship, the kind that President Kagame has given continentally for domestic health financing and for his own Rwanda insurance system. All right, this is where I want to land in closing. We no longer require countries to choose between Bismarckian and Beveridge systems. That's the past. That binary is just a distraction. Countries are supposed to make a sequence of stage by stage decisions about who does what. Look at the patient centered value chain. Who should do what? From the time the patient is entering into the system to the time when you're adjudicating a disagreement. Each decision is technical, each decision is political. Together, these decisions determine whether premiums stay affordable and whether public money actually buys health. Thank you very much. Let's see each other in the next practical session that will examine your health insurance and make it work. And provide your comments below, and we'll use all the experience we can help you answer some of your toughest issues that you're facing with your insurance system in your country.